Okay, well, hello. It says I'm recording, so that's good. Today we're going to cover chapters 5, 6, and 7. I hope to get everything finished up here. So without further ado, I'm going to go to, I should get my screen up so I can share it with you. Okay. What's going on here? Okay, here it is. Okay. Let's start with chapter 5. Okay, here we go. One open. All right. Slideshow from the beginning. Okay. Nope. Show back to here. And I'm not sharing my screen yet, sorry. So we will share this screen and share. All right, so okay, I don't know what's going on, but hopefully you guys are seeing my screen now. And we will talk about, now see your application, good. We'll talk about chapter 5. Chapter 5, we have our objectives here, which are basically, like I've said before, at the beginning of the chapter. So it just tells you what we're going to cover. The nurse's use of necessary components involved in the building and enhancing the nurse-client relationship, trust, interest, empathy, acceptance, and positive regard. Describe the importance of self-awareness, explain the importance of values, beliefs, and attitudes, and your self-awareness of those of it for yourself. Identify self-aware issues, define Carper's 4 patterns of knowing, give examples, describe the difference between social, intimate, and therapeutic relationships, describe what the phases of the nurse-client relationship, according to Peplau, and explain the negative behaviors that can hinder or diminish the relationship. A therapeutic relationship is very important in this for your patients. If you don't know somebody, you don't trust somebody, you don't have a good working relationship with them, you're not going to share with them what needs to be shared, and you're not going to be able to do the work that needs to be done. So it's very important that we remember to do that. It's very important, crucial to success. Trust. So trust. Like I said, trust is probably our most important behavior that we need to have with our patients. They help us, or they can be shown through caring and interest and consistency. That's a big one. Keeping promises. So if you make an appointment with your patient and you say that you're going to be there to have your communication with them at 1:30 p.m., you'd better be there at 1:30 p.m. because that is a promise, and that is a trust issue. It's also part of professionalism. Congruence. Congruence is making sure that what you're saying, or the words that are coming out of your mouth, and the way that your face is speaking, your nonverbal communications, even turning away from a patient instead of facing them directly, can show a miscongruence between what you're saying. Oh, I care about you, but I'm going to like look over here. So we don't want that. So interest, self-comfort, being aware of who you are, being aware of your strengths and limitations, understanding your patient and being interested. Because people in general, I don't know about you, but I can tell when people are lying to me. So people in general can detect dishonest behavior. Commonly, it's through micro features on the face or micro expressions on the face. But it's a little bit later if you want to get into that. It's like bachelor's or master's level. Empathy. You guys think you know empathy. Empathy differs from sympathy. Obviously, sympathy is feeling for someone, whereas empathy is feeling with someone. Um, uh, a good way to look at this is you don't want to say things like, I understand what you mean, or that's so sad. Those things are more sympathetic. That's your interpretation of their feelings. It's very, it can be seen as insulting in some people. Um, you don't want to project your feelings or your interpretations on what they're feeling. You want them to tell you what they're feeling. Then we have acceptance, no judgments, no boundaries. People tell you, that they have the left butt cheek tattooed, or pierced or whatever. I don't care. You just accept that and say, oh, okay, yeah, whatever. That's you do you, boo. That's kind of what I always said to my, not my patients, but my children. And then unconditional positive regard. This is a huge, 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 huge one. You look at people, they come in and they're in a rough patch. They maybe have rashes or scabies or lice or bed bugs, or, they may have these horrible scratches where they're itching and it's like dug into their skin, and they have weeping wounds and things like that. Your face can't be like, you can't do that. Your unconditional positive regard, being non-judgmental, is accept the person where they live. This is who they are. This is who I'm going to be taking care of. That's my job as a nurse to do that, and to do it without an attitude. Okay. I'm not going to make them feel less. I'm not going to make them, feel like they don't count or they're unimportant, because their situation is rough right now. My job is to help them help themselves through this patch. And you'll hear me say that again and again and again. In psychosocial nursing, you cannot fix anybody. They have to fix themselves. But your job as a psychosocial nurse is to help them get tools, or to create tools of their own, to become capable of healing themselves. Um, you need to be self-aware. You need to know who you are. You need to know your values, what you choose, what you prize, what you act on, your beliefs, your attitudes, and you need to be culturally aware of your patients. Now, I can say that, and some of you are like, oh, I'm very culturally aware. Well, not in all cases. If you go in to a room where I'm at, um, my family is Melungeon. It's from southeastern Kentucky. There's a lot of mistrust of people down there. Not saying that um, I don't trust you, but my culture, or where I'm from, that part of Kentucky, they have a lot of misgivings, especially with medical professionals. So when you come in and you have a great big smile on your face and you, hi, I'm here to treat you, blah, 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 I'm not going to trust you, period. Because the only person who shows me that much teeth is a dog when they get ready to bite. So culturally, you have to be aware of where people are coming from. You have to know what you value. Do you value life? Are you a pro-life person? Can you take care of someone who has had multiple abortions, or somebody who is promiscuous and uses the morning after pill? Can you handle that? Can you look at them non-judgmentally? So it just depends on where you're at and who you are. So you have to really study and look deep into what you are. And when you're in clinical this term, I think what you're going to find out is that there is so many different people out there, and their life stories are very similar to yours, except for one or two things that are a little different. And that one or two things, or those one or two things that have happened to them or have been orchestrated by them, something like that, are going to be the difference between you and them. Can you accept them knowing that you would have chosen differently? So rising above that, rising over that, accepting them for who they are, and knowing that you could just as easily be in that same situation is something you need to think about. So, is the following statement true or false? Nurse displays empathy by showing feelings of concern and compassion. That is false. Empathy is perceiving the client's meanings. Sympathy is where you show them concern and compassion. Oh, I'm so sorry that happened to you. Yeah, no. Okay. Treatment of therapeutic use of self. That's what you are. We don't need stethoscopes. We don't need bandage scissors. We don't need tape. We don't need any of that stuff. We just use our minds, and we use our body language, and we use our verbal and we use our nonverbal communication. So all aspects of the personality, experience, values, all of that for you and for your patient have to be perceived and understood. Okay, so the burden is on you to understand who they are and where they are, and then to understand who you are and where you are. So the burden is on you. It's not on them. This kind of idea was developed by Hildegard Peplau. She's a nurse theorist. And she came up with this, saying that we have a lot of actions that come from conscious and unconscious responses, which you'll find in your patients if they have experienced a situation, how they're coping or their maladaptive coping has been the key to how things are changed in their life. There's another way to look at it. There's the Johari window, which you can use. It's in your book if you want to do it yourself. It has 4 quadrants to help you learn about yourself. There's open and public self, the blind or unaware self, the hidden and private self, and what you don't know. Now, most people know their open or public self. Some people say, gosh, that's fake. Gosh, I don't want to deal with that. Those type of people I just can't stand. It's a common thing that happens. We walk past people and we say, hey, how you doing today? And they look at you and they go, hey, yeah, I'm fine. How are you doing? Well, okay. It's called meta communication. And we all know that's public. We all know that it's just kind of a way of greeting people. But what if you said to somebody, hey, how you doing today? And they proceeded to tell you how they have a cancer diagnosis and how their spouse is leaving them and that is really something that most people will be uncomfortable with. Okay, so that is something maybe you don't know. So that could be part of the unknown domain. Then we have things about ourselves that we are unaware of. I was recently told that I have a different perception when I'm with students live versus when I have a recording. And I was unaware of that, but after I thought about it, I'm like, well, yeah, because I don't have somebody I'm looking at and communicating with non-verbally. So the way I say things is going to be different. The meaning is not different, but the way I'm going to express them is going to be different because in this situation right here, I'm talking to myself. There's nobody here. And it's much more different when you have someone to receive what you're saying and to give back to you. So but that was something I was quite unaware of. And then we have our hidden or private self. And, I don't have any personal examples of that, but we all know that there are things about ourselves that we don't want other people to know. And we keep those to ourselves, and that's okay. If somebody wants to keep something that private, that's fine. You just unconditional positive regard, accept them for who they are and their secrets they keep. If they trust you and the secret is related to their psychopathy, they're going to be talking to you about it. Just be willing and able to receive what they're giving. The goal is to move from 2 and 3 and 4 into number 1. So, like I said, you want to meet them where they're at. You want to guide them towards this openness or this trust relationship with you. Now, it's not necessarily considered an open thing, as in open to the public or their public self, but open to you in a therapeutic relationship. Oh, there's the Johari window. Okay, it's very interesting. It's a concept. To be honest, I like it. It's interesting. I don't really give you much to look at as far as quizzing and things like that, just because it's a little more psyche than it is more psychosocial. So, but it's something you can look at, not something probably I'll test over. Patterns of knowing. How do we know what we know? We look at things. We see them, we have preconceptions of what's happening in situations. When you walk into a patient room, they're lying in bed, their eyes are closed, they're breathing easily, you assume they're asleep. Okay. Can you say that they're asleep in your documentation? No, because you won't know that they're asleep unless you wake them up and ask them, were you sleeping? Because you don't live inside their head. So you don't know what they know about themselves. There are and that's a preconception. So kind of remember that. There are 4 ways of knowing, according to Carper. Empirical, which we get from nursing science, which everybody, At this point, you guys should know how to use or give an injection from an ampule. Snap the ampule, filter needle, no glass, give the injection, go from there. That's nursing science. That's empirical data. Personal data, things you've experienced, your personal life experiences. Ethical data are moral from nursing knowledge. This is usually people's right to themselves, their autonomy, mainly ethical dilemmas, those type of things that you think of in deontology, utilitarianism, which we talk more in chapter 9 about those things. So, and then the art of nursing, which is psychosocial nursing, how you express yourself, how you engage on a human level with other people, yet maintaining a professional boundary. And then that fifth pattern of knowing is unknowing. So what you don't know. I mean, there's a lot of things I don't know. I have been a nurse for over 30 years, but I'm not a surgeon, so I don't know how to do brain surgery. And I know I don't know that. So if you know what you don't know, you're ahead of the game. There's different types of relationships that we have with our patients or anybody in general. We have a social relationship, which you guys can look around the classroom. You look beside the people you're sitting beside, buddies, friends, colleagues, peers. You share ideas, roles get shifted around. You don't look at how it's going to come out in the end just because it's social, it's fun. It's just what you do. The purpose is friendship. The intimate relationship, I think you guys do know intimate relationships is a commitment of at least two people. It can be an idea, not just a person. It can be a concept. You can have an intimate relationship with a concept. So like right now, some of you may have an intimate relationship with becoming an RN. That is all you live, you breathe, all you do is getting through. That's an intimate relationship with becoming an RN. It's a concept. Actually, it could be considered an intimate relationship with yourself too. So therapeutic relationship is not social. So we don't want to be our patient's friends. It's definitely not intimate. Therapeutic focuses on your patient's needs, not yours. Client's needs, experience, feelings, theirs only. So your job is just to guide them along self-discovery. You use your communication skills, your personal strengths, and understanding of human behavior. You make agreements on areas to work on. You evaluate if whether or not you got your goals or not. And you really have to be very self-aware at what is going to stop you because it can hinder your relationship. Say you're somewhere and you're walking your patient in the hallway and you say, "Hey, did you see the OSU game last night? What's going on? They don't know what they're doing. Michigan beat them." And the patient says, "Yeah, that's cool. Whatever. I like Michigan." Yeah, that's a social relationship. That's not a therapeutic relationship. And stating that and showing you have adversarial interests is actually going to be detrimental to your therapeutic relationship. So don't do that. Don't do that in a therapeutic relationship. So a social relationship usually involves communication with the person because of friendship or task completion. And that is true. That's the social relationship. The therapeutic relationship has phases. There is the orientation phase. That's where you come onto the floor. You say, "Hello, I'm Joe Blow. I'm here to be your nurse. I'm going to be here from 7 until 3:30, or in some cases, 7 until 5:30. And we're going to have a couple of communications in here. The purpose is for us to get to know each other. Okay, and for me to help you help yourself." So in that's orientation. That may last, a couple of days until they get used to seeing you. In psychosocial nursing and clinical, we won't necessarily achieve a truly therapeutic relationship. We'll get very close to one, but we only have them for 8 hours. So if they are consistently with you for that 8 hours, you're consistently showing them trust. You're showing them that you're going to be there. You're showing them you're going to listen to them. That's going to move us from the orientation phase into the working phase. This is where you help them identify and explore what's going on and how they feel about it. Okay. Sometimes they have come in because they have tried to kill themselves. We had a gentleman a couple of semesters ago, took a shotgun, kind of maneuvered it so that he could hit it with his toe, shot himself through the chest, not through the heart, but through a lung. Had chest tubes and everything, but when he was stabilized, he still had a wound, and they brought him to psych, and we had to do dressing changes. I found that that was the most vital time when I was doing the dressing changes, to talk to him about how he had been feeling in those situations, what had been his thought processes, how was he coping with those situations. And I mean, you can't say, oh, you were coping horrible, you tried to kill yourself, you shot yourself. No, you can't do that. You just have to listen to what they say. And it turned out he'd lost his job, his wife was divorcing him, it was just rough all around, and he didn't feel like he was coping very well at all. And they will tell you things that they don't tell the nurses on the floor. And if that's the case, you need to tell the nurse on the floor what the patient has shared with you. And I know you're going to say, that just destroys the trust relationship. Well, it's for safety. That really should be the only time that you're doing that. Then the termination phase. Again, and during the orientation phase, you let them know how long you're going to be there, because when you leave at the end of the day, you have to say goodbye to your patient. Hello, I've told you this morning I'm going to be leaving at 3:30. I'm getting ready to leave the floors, or anything else you'd like to talk about before I go. That's very helpful. If you set those boundaries early in the day, you're not going to have very much trouble with termination. You'll be able to walk out. Sometimes the phases shift and move all around. Sometimes you go in for orientation, you tell them all that stuff, and they say, I don't want a student nurse today. Get out of my face, you worthless, whatever. And get used to patients calling you names, because they may, the language that public in general can be hurtful. So how you understand what they're talking about is probably the best, and how you relate to it is very good too. So, but those phases, if he wants to terminate with you, come find me. Say, hey, he wants to terminate with me. He doesn't want me as a student nurse. I've usually talked to them all and asked them, are you willing to have a student nurse? And if they say, yeah, or they say, maybe, then you go in and see them and they say, oh, definitely not. Then you come tell me and we'll get you somebody else. It's not a problem. Okay. Let's see, the orientation phase, meet the nurse client, establish roles, purposes, identification of problems. I think we just talked about this. Exploration, transference and countertransference. During your working phase, that's where these phenomenon is what they're called. Phenomenon in psychosocial nursing happen, transference and countertransference. Transference is where the patient makes you feel a certain way, such as you're talking with your patient and you're like, God, they remind me of my brother, the way they are talking about, their classmates or whatever. Oh, remind me of my brother. That's transference, because now everything you feel about your brother, you've put onto this patient. That's not good. It's going to hinder the relationship. Countertransference is when the patient feels things about you, and they may say to you when you walk in the room, gosh, you're a pretty girl. You remind me of my granddaughter. Well, guess what? Now you have all the characteristics of the granddaughter in their mind. And that's not good either, because it depends on how they like their granddaughter, how much they share with their granddaughter, and what that relationship is reciprocal from their granddaughter. So you have to really move away, rise above transference, countertransference, say to yourself, if this reminds me of my brother, this is not my brother though, and move away. Countertransfer and say, oh, that must be nice that you have a granddaughter that's so pretty. Good for you. And just move on with it. Just don't even think about it. Okay. Those phenomenon are very interesting, and I might quiz on those. Termination, patient's client problems probably won't be resolved, but we're working on them since we have such a short window of time with them. But it is definitely when the relationship ends. Occasionally, if you have not terminated early enough in the relationship, they may try to avoid it and keep you there. I've had a student come to me. She was carrying sheets. I'm like, what are you doing? And she said, the patient told me if I left, they were going to hang themselves with their sheets. So she took the sheets and left the room. Um, Definitely, I don't mean to laugh, but her carrying the sheet, I still see her. Um, anyway, but that is a reason why you have to get into that orientation phase early on and terminate. Say, hey, I'm going to be here at this time, so they are anticipation of you leaving. And even though you build a therapeutic relationship, they know this is the boundary and this is when you're going to leave. Yeah, boundaries. You can't have inappropriate boundaries. So, nurses, a lot of times, especially novice nurses, when they're going to psychosocial nursing, think they will say things, excuse me, say things that they're going to make a mistake. Talking about suicide is not going to make the patient try to commit suicide. You got to talk about it. Um, Talking about or saying the word why, that's another big no-no. You cannot say the word why because it's real accusatory for the patient. So if you say that, that might end the relationship. Well, doing non-therapeutic things happen, but you can recover from those. It's okay. Being sympathetic instead of empathetic, being non-accepting or avoiding them. These are all things that are going to diminish the relationship, and that's not what we want in psychosocial nursing. There are different signs of abuse in nurse-client relationships. Patients can abuse you, and you can abuse patients. So, and it's more than just, physical abuse. It could be verbal, could be emotional. Take a look at the box. I'm not a big fan of people who say, gosh, this patient is just demanding drugs and I'm going to teach them a lesson and I'm not going to give them anything. Well, that's abuse. So think about that. Not that we give drugs and psych, but that is one example for the future. So during the working phase in a nurse-client relationship, which action would occur? Working phase. So is it the contracts, the feelings of loss, feelings are examined, expectations are clarified? Which action? Client's feelings are examined. That's when you're working on it, okay? Outlined and contracts are established, expectations and all that's during orientation, feelings of loss are addressed is during termination. So Hildegard Peplau, she did say that we had different roles that we play for our patient. We can be the teacher, we can be their caregiver, we can be their advocates, their parent surrogate if it's a child or a younger person, or someone who's a little developmentally delayed. We can be their parent surrogate. These are all different roles that the nurse can portray for the patient. And it's okay if you assume multiple roles. I kind of expect that you're going to. I expect everybody to be a caregiver. I expect everybody to be an advocate. I expect everybody to do teaching with your patients if you need to. Hildegard just said that when you're doing those things, you have to realize where you're at and be very self-aware of where you're at. So you're not interjecting into who they are. Now, doing this over and over and over again can cause something called compassion fatigue, which can lead to burnout. So you have to have ways to get rid of, I call it junk, get rid of your junk that you carry with you when you leave a relationship with a patient. Some people, they say, gosh, I reevaluate what I value. Some people go home, write it down. I was always the talker. So I would talk to people about how I was feeling, usually my clinical manager or a colleague or a friend about how I was feeling with this patient. If it was patient specific, it would obviously be somebody there on my floor, not outside, so no HIPAA violations. You can read about things like that, but really, for me, the dialectal therapy worked the best. If you feel that journaling would work better for you, that would be fine too. Okay, chapter 5 is done. So we're going to go back and go to chapter 6. Okay, you're back here with me. I gotta go back out and see where I can find chapter 6. Let's go here, it's not there. Here, here, here. Okay, modules. Chapter 6, okay. Okay. It's opening, opening, opening. You're gonna hear my alarm go off here in a minute. Just got 30 slides. I think I'll just close with chapter 5 today, and then we'll do chapter 6 and 7 on another day, since my alarm isn't gonna go off. It means I've run out of time. So I will go ahead and close it out today for chapter 6, and we'll do chapter 7 and chapter 8 next time. Thanks for listening.